Dr. Michael Ciminiello is in studio with us. In his background, actually I should say in your background since you're right here. Why am I going to talk about you in the third person? You're an arm's distance away from me. You, in your background, you were drafted by the Detroit Tigers, and following your baseball career, you went on with a second passion of yours and have focused on a medical career. You had won the Carl Yastrzemski Award during your senior year in high school back in the year of 1992. First of all, it's nice to have you join us on our program.
Oh, thank you for having me.
A lot of areas where I want to go in this discussion, but when you were drafted, how big a kick was that?
Well, any kid who plays baseball growing up has a singular goal, and that is to play for whatever their baseball favorite team is. And mine was the Yankees, and I was hoping to get drafted by the Yankees. However, any team would have been good. And when I got drafted, I remember when I got the phone call, because I was on the golf course playing with my brother, and I got the call, and we were super excited. We rushed home, and we made plans to meet the scout who came to my house, and we had a big signing party. And I remember looking through pictures actually yesterday, looking at those fond memories and how young I looked and how much more hair I had and how much skinnier I was back then. It was just very, very exciting time, and I was the beneficiary of an incredible upbringing. My parents, both my mother, my father, my aunts and uncles, grandparents were vitally important to my upbringing and were elated. And that was the culmination of one of the things that we did as a family together, and that was baseball. I mean, there's four siblings in my family. I'm the oldest, but we all played Division I college sports. Baseball, three of us, we were three boys and a girl. My sister, Christine, played varsity softball at Adelphi for 4 years. My brother was the captain of the Providence college baseball team, and he is now an orthopedic surgeon in Danbury, Connecticut. And my youngest brother played at Monmouth University and now is in commercial real estate. So, baseball was what we did. I grew up in a house where I had a little league infield in my backyard and a batting cage, and we didn't have a lack of things to do, so we stayed out of trouble and had a lot of fun doing it.
I like that when you said that you were looking at those pictures and realizing how young you looked then. Life as a surgeon, why did you choose to go that route?
Well, that's easy. From a very early age, I knew I wanted to be a doctor. I don't know why. I just did. And when you're making a decision as to what discipline of medicine you're going to pursue, there's a branch point. It's either medical or surgical. And as an athlete, we do things, and we, whether it's either hitting a baseball or a golf ball, and the fruits of what you do are evident right away. And that's probably the reason why surgery was appealing to me. I went into medical school thinking I was going to do orthopedic surgery. Then I changed my mind and actually was on the road to become a heart surgeon, and decided that in the end my life would be best spent as an orthopedic surgeon. And then I chose within orthopedic surgery to be a hip and knee replacement specialist because those two operations are predictable, reliable, and have the ability to impact people's lives for many, many, many years. And I enjoyed doing the operations, just like I enjoyed taking batting practice and hitting a baseball. I enjoy the actual mechanical process of going through the operations.
Similarities between the two?
Well, just like taking care of just like baseball, taking care of patients in any discipline is a team sport. It really is. You can't take care of patients in a vacuum or in a silo. You must rely on the team in the operating room, your nurses who are checking on the patient, checking all the medications and allergies and things like that, the scrub nurse or the scrub tech, your first and second assistants, the anesthesiologist, the implant representative who is in the room with you to provide you information if you need it, and also make sure that all the inventory is there and up to date. And you can't do that all on your own because your focus has to be on the operation, and you must be able to trust your teammates to support you and do their job. And that's the same thing as baseball. I mean, you can't, if you're the catcher, you can't be the shortstop, clearly. So
that'd be a little bit difficult to play the two positions simultaneously.
No, you'd have to be pretty fast. So you really have to be able to let go of the control a little bit and control what you control. Even though you're the master of the ship, you have to train your team to do their job so that you don't have to worry about that. But you also have to manage as well and make sure everybody's doing what they're supposed to do, because ultimately I have to know everything because they're my patients. And the way to do that is have the members of your team completely bought into the process, as insofar as that they all think that that patient is their patient. So their job is, it could be as simple as the guy who's cleaning the room. He does it perfectly because, the way you clean the room has an impact on the patient's outcome. So you have to build a team. So being a member of a team my whole life has been an asset to me, because it's no different in taking care of patients in the operating room or otherwise. So I think it's very, very similar, and I'm thankful to be, have had that opportunity, because it's not something that I have to even force. It just happens.
Why'd you come back to New York to do it?
I came back to New York because my family is on Long Island. I have my mom and dad, my mother and father-in-law, my siblings, except for one, are all on Long Island. And I had an opportunity to stay in Philadelphia, where I trained at the Rothman Institute, and I decided that in the end, what was most important to me was spending as much time with my family as I possibly could. I thought I benefited tremendously from an upbringing that involved multiple generations of my family, and it was the biggest gift that I have, and it is the biggest gift that I have, and besides my own children. So I would like to have my 4 kids, have that opportunity as well, to be part of a family, that is closely knit, that has, we're Italian, so I have Sunday macaroni together, as much as possible, and that's important to us. And, it's nice to have the children with their cousins, and, it's hard to do when you're 3 or 4 hours away, even though it doesn't seem that far. 3 or 4 hours, in a car is tough. So, that was the reason. Plus, I love Long Island. I thought it was a great place to grow up. I think it's a unique place to live. You have access to some of the world's nicest beaches, and you can get into New York City in half an hour, 45 minutes. The school districts are great. It's just a tremendous place to live.
Take us into what this is like for us as lay people. We don't get to experience this except literally as the patient going into an operating room. What's it like to actually work in an operating room? In terms of the atmosphere, you mentioned the teamwork, but what's the mood like?
Well, it's an interesting question because people ask me, what does it feel like? I get that question all the time. And I can honestly say my operating rooms feel very similar to the atmosphere on a baseball field when you're the player. Yes, there's pressure. You feel the pressure, but you're in your element. So it's not, for the staff, it should not be overwhelming pressure. It is a place, for me, a place of comfort, a place for me to do my work and to affect change and help people. And it's quite enjoyable for me. Now, for a patient, many of them are scared when they come back. They don't know what to expect. It's very hard for people to give up complete control, but they really have no control once they're coming back. They know they're going to be placed under anesthesia, and you have to temper your exuberance to be in the operating room as a surgeon with that caring and compassion that you need to provide those patients to calm them and provide them with the best experience possible.
Is there anything humorous that happens in the operating room?
Quite humorous. There's a lot of things that patients can say while they're under the influence of anesthesia. Pretty much all of my surgery is done without general anesthesia, but patients get sedation, and it acts as a bit of a truth serum, so you can get some harassment from the patients. Nursing staff, you can give people a hard time. It like I said, it reminds me of some dugout conversations that I've had. Where you just there's nobody really listening, and you're just kind of goofing on each other a little bit and trying to keep the atmosphere as light as possible without taking the focus off what's important.
You almost have to treat it, though, like Las Vegas, because what happens in there stays there.
Yeah,
right?
pretty much. Yeah, pretty much.
I had an interesting experience. You mentioned that about anesthesia. I guess it was 2003. I was having an operation. Mike, you'll appreciate this. Where I was having some moles removed from my body, so I was under anesthesia, and it was supposed to be about an hour and a half long procedure that turned into a 4.5 hour operation because these things were a lot further in than even the surgeon had anticipated at the time. But there was a point in the operation where I woke up and sat up and started talking to the doctor about a black bear that I had known. And the doctor and I had quite the conversation about this afterwards. So, naturally, it was a thought that I had heading into this discussion today. What must this be like in the operating room? Because, there's got to be this focus there, but there's also got to be a sense of cooperation and almost kind of a looseness that will allow you to be flexible for whatever potentially can happen.
That's true. Absolutely. You basically have to be prepared for everything and anything, even though it's a controlled environment. The X factor is the patient, and you never know how a patient's going to react to anesthesia or giving up that control.
Dr. Michael Ciminiello is in studio with us on our program on the Fan this Sunday morning. As I mentioned, he was drafted by the Detroit Tigers. Following his baseball career, he decided to pursue his second passion. He is a surgeon, leading hip and knee surgeon, and he's joined us in studio, give us some perspective on the world in which he works. A little bit later in this hour, just mentioning the fact that you are a surgeon and the area of specialty, I have a feeling. Trust me, after doing the show for many years, I have a feeling, and I think I'm right on this. We'll wind up with some people who will want to ask you questions. I want to ask you about the area in which you work, area of the body, because we're talking about basically about joints.
Correct.
Here. You know, people talk about having, a hip replacement or a knee replacement or knee surgery. This word meniscus will be thrown about literally by people who call here. What is it like? What's it physically like to work on a joint? I mean, what do these things actually look like?
Well, the knee joint is a very complicated joint. It is the bone is covered in a very beautiful, very well engineered, if you will, substance called articular cartilage, and it's very shiny and lubricated. And in when I'm operating on them, they're not so. The articular cartilage is gone, and you could see from almost a visceral perspective why things hurt, because you look at what normal's supposed to look like, and then you see what people live with and walk on, and you say, ow, that has to hurt. Sometimes it looks worse than others, but it is the difference in day-to-day appearances of the knee when I'm operating is astounding, and I'm only doing 2 procedures, hip replacement and knee replacement. So the variety of patterns of arthritis and severity and interesting things that you see on a daily basis are astounding, considering you're only doing 2 operations. The nice thing is that with the variety of all the things you see, there's always the same structures in the same place, which bring you back home so that you don't get lost. And the hip is actually a simpler joint than the knee, and our ability to reconstruct the hip joint is, I believe, a bit better understood than the knee. Yet our understanding of the knee reconstruction is excellent as well. So it is a challenging every day, because every patient has subtle nuances that if you do only 2 operations, you pick up on. Somebody who doesn't do as many or does more may not pick up on the subtleties, which is really what intrigues me.
When you talk about reconstruction, what exactly is involved in that? Because we hear this term again used a lot.
Well, reconstruction and replacement are really synonymous. Primary hip and knee reconstruction or replacement are the same things. A hip replacement is basically removing the area of disease, the bone and cartilage, from the femoral head, the femoral neck, and the acetabulum, okay, and resurfacing
the what?
The acetabulum, which is the hip socket.
Okay.
Thank you. And replacing that with cartilage, with metal and plastic, and the metal is titanium, and the bone actually is able to grow onto the titanium surface and become solidly fixed to the metal, which acts almost as a biologic glue. And we think, although it's not perfect, that once the bone has knitted to the prosthesis, that it will, in many ways, never come loose, unless there is something that makes it come loose, either infection or other things that are complicated.
Does that happen with any regularity, those sort of
loosening? Yeah, it does happen for a variety of different reasons. However, if we had a perfect world and we were able to follow up our patients and make sure that they come in every couple of years to get an x-ray, we could potentially limit that loosening for certain reasons to close to zero. Infection is one of the things that can cause loosening. Now, infection is one of those things that we try to prevent, but is really a patient's at risk for infection in their joint for the rest of their life. However, the number is somewhere between 2 and 5%.
Is there? I should have asked you this earlier. Is there a typical or a way of characterizing the typical patient that you see, or am I generalizing too much?
Well, it's a very good question. It's a little known fact that the demographics of who is getting joint replacements now in the United States is 50% of patients who are 50% of patients are 65 years old or younger. So it's not just a Medicare population now or an older aging population that are getting their joints replaced. People nowadays don't want to live with incapacitating pain in their knees or hips, and we have good solutions to fix their pain and get their quality of life back to where they want it to be. And that's what joint replacement surgery is for. It is to improve quality of life. It is not a life or death operation. Nobody's ever died from arthritis. Have people been put in a wheelchair? Absolutely. What happens when you stop moving? You get depressed, you eat more, you gain weight, you can get diabetes, you can get a lot of different things. So joint replacement, although it may be scary to a lot of people, is something that is purely a quality of life operation, but should not be something that should not make people fearful until all the information is gathered by the patient. A lot of patients come in, I know this patient who had this problem or this patient who had this problem, and of course everybody is afraid because they are focusing on the negative but aren't aware of all the positive that is out there.
And how much follow-up is involved? I mean, how closely does somebody who's had joint replacement, how closely do they have to be followed? Is this for the rest of their lives?
Yes. In my opinion, to do it properly, and every surgeon has a different way they go about it, but the way I run my practice is I see my patients initially 2 weeks after surgery. That is purely to make sure that the incision is healing well. And then I see them at between 4 and 6 weeks to make sure in the knee that they're getting the proper range of motion, the straightening and bending that they need. Make sure that they're progressing well. And then the hip, just to make sure that they're doing their physical therapy and walking and doing all those activities of daily living that they got their hip replaced for. And then at 6 months after surgery, just to, again, assess their progress. And those visits are really quick visits. They're x-ray, physical examination, 10 minutes of actually patient-doctor time that is important. And then 2 years after the initial operation, and then anywhere between 2 and 5 years in those increments. And the reason why, as patients get further away from their joint replacements, they don't come back is because they feel good and they don't need to come back. But I like my patients to come back every 2, 3, 4 years just to make sure that the joint is continuing to do well. And look, these things are mechanical. They don't last forever. They're not designed to last forever. I wish we had something that we could say will last forever, but we have some things we think may last forever, but we're not sure. So as far as I'm concerned, I would rather catch a problem when it's a small problem and I can intervene, even if it's surgically with a relatively small operation, as opposed to a major operation that is not as predictable.
Are techniques that you are using, techniques used in this specific area of medicine where you are focused, are they changing? Are they evolving?
Yes. Orthopedics is, in not just joint replacement, is one of the subspecialties of surgery that are pushing the envelope in new techniques all the time. In joint replacement surgery, there's always a push for minimally invasive surgery, less invasive surgery, faster recovery, better outcomes, and the procedures are changing in the way they are done. However, the actual important components have not changed, meaning the principles have not changed. The principles of how do you put a hip replacement in properly so that it works for 30, 40 years have never changed. They are the same. How you get there has changed. Are we sure that the newer ways of doing it through smaller incisions are significantly better? I don't know yet. That's the answer, is I don't know yet. I don't know if they are significantly better. I think we've made a lot of improvements in our procedural treatment of patients, but I'm not sure if anything that is so cutting edge is that much better.
Dr. Michael Ciminiello is in studio with us on our program on the Fan this Sunday morning. As I mentioned earlier in our discussion, he's a leading hip and knee replacement surgeon. He has shared an awful lot with us in our discussion. We're going to try to work in as many people via the phone as we possibly can in discussion in this portion of our program, but I want to also ask you to mention your website, because this can be a resource for people who can't get through to us in our discussion today.
Great. Thanks, Bob. The website is www.hip, knee, doctor, dr.com. That's www.hipandkneedoctor.com. On the website, there are multiple discussions that I give in the upcoming events section that if you can't get to listen today, maybe you can come and hear me speak about one of my passions, which is hip and knee replacement surgery.
All right, let's go to the phone. As I mentioned, I had this sneaking hunch that there'd be people who wanted to talk to you. WFAN's toll-free line, 877-337-6666, brought to you by Mohegan Sun, the Northeast premier entertainment destination. So you mentioned doctor, free legal advice, free medical advice. People come out of the woodwork.
Yes.
All right, let's go first to Rob in Lake Success, who's been holding on for some time. Rob, good morning. Welcome to the Fan.
Good morning, Bob. I got to say, it's funny. This has been a great hour. I'm a doctor. I'm a podiatric physician, and your story is very similar. I was a college track star and ran marathons. I was a distance runner, and I think the discipline comes from us competing in sports, or anybody who competed on a high level. It continues in life. As I continued, I did not want to be a doctor. I was a phys ed teacher, changed over, but the discipline from my sports got me to this point and became a physician. My question, though, is, I've been in the operating room, and you don't want to know, Bob, what goes on in there, because we're like the coaches, okay? The head coach of a football team. We're overseeing the other departments, the anesthesiologists, the nurses, the residents, and you're really in charge, and you're on the clock. So, Doc, as you know, we have a certain amount of time to get this surgery done. But here's my question to you, because as a podiatric physician, we're a little different. I myself, from the running, all the years I competed running 100-mile weeks in college 25, 30 years ago, developed knee issues. My lateral horn I might have a slight tear in the meniscus of the lateral horn. My question is, Doc, I read in my readings that there is some blood supply in that area. Will this potentially heal? Cortisone, I really want to stay away from a cortisone shot, even though I give a lot of them myself. Cortisone shots, meniscus tears, we haven't really touched on that. Give me a little basis for the lateral horn repair by itself with the blood supply, or will they ultimately need to have that surgery? And a great show, and thank you very much, Doctor, for your time.
Oh, thank you. The lateral horn of the meniscus is, some of it does have blood supply. However, most tears are not fixable because they lack a blood supply. And in all likelihood, if I were just based on percentages and statistics, the meniscal tear is likely not fixable, meaning repairable. The more likely surgical intervention that you would need would be a debridement of the meniscus, which cleans out the loose edge of the meniscus and leaves the remaining meniscus intact, so that it doesn't continue to tear further. When you tear, I make an analogy for patients in describing this. When you're tearing a piece of paper or a newspaper, it's often very difficult to tear it initially, but then once you get it torn, it's very easy to tear, and that is what you want to avoid. Not every meniscus tear needs to have surgical intervention. Certainly, cortisone is something that is an anti-inflammatory, will take away the pain if you're having a lot of pain. There are other injectable supplements available now called viscosupplementation. Those are potential treatments. And physical therapy is also something that's helpful as well. So just because you have a meniscus tear doesn't absolutely mean that you need any surgery at all.
Okay, hopefully that answers your question. Thank you for your call this morning, Rob. Let's go next to Joe in New Rochelle. Joe, thanks for holding on. Welcome to the fan.
Morning, gentlemen. I have a problem with my left knee, and it's been ongoing for a couple of years. And I'm told I have a little tear in the meniscus, but I'll go months and be fine. And then I'll have 3 or 4 days where I can barely get out of bed and move. So what would my options be for a situation like that? I mean, I personally am trying to, quote-unquote, avoid having any surgery done.
How old are you, Joe?
53.
So even if you have a tear in the meniscus at that age, it's most likely a degenerative tear. And what I mean by that is bone is harder than the meniscus, okay? And if you have any degeneration of the bone or of the cartilage, the bone gets exposed and rubs against the relatively soft meniscus and causes it to degenerate. So you probably have a little bit of arthritis in that knee, maybe even more than a little bit of arthritis, I don't know. You may benefit from some injections. You've had an MRI, I assume.
Yeah, I have. And the thing is about injections and that is they tell me that there's like a time constraint how long it would last. And like I said, I go a couple of months sometimes, and I'm fine anyway. So it's very
right.
I'm kind of like in that middle gray area. I'm not really sure what to do at this point.
Yeah, the injections are something that you can consider, but again, they don't last forever. And I would put up with it as long as you can put up with it, and then start pursuing treatment options.
Well, all right. Thank you very much, Doctor. And Bob, thank you for your show. I enjoy it.
You're welcome.
Thank you very much for your call this morning, Joe. We'll stay with folks via the phone. 877-337-6666 is our number here at the fan. Where are we headed to next, Dove? We want to jump over to Craig in Old Greenwich. Is this Craig Swan?
This is Craig Swan. How you doing, Bob?
All right. Good morning. How you doing, Craig?
Good morning.
Hi, Craig.
Well, I wanted to call in because I just had my knee replaced 7 weeks ago by Dr. Irving up in Milford here. Mm-hmm. And, I kind of wanted to let people know that if they wait too long sometimes, it can affect other parts of your body. I limped probably for 9 months before I had the surgery, and I had bursa sac up there by the and the hip got inflamed, and it's just settling down after 7 weeks of therapy.
Well, how's your knee doing? Your knee doing well?
My knee is great. 7 weeks into it, and the pain's gone, that I had for 40 years.
Yeah, it's amazing how much pain people actually put up with for as long as they did. Anecdotally, my grandmother was less scared of having 2 valves replaced in her heart than she was of having her knees replaced.
Right. Well, that's what I did. I held off too long a little bit and affected my hip a little.
Yeah. Well, that you're not unique. I think there's a lot of people out there who just put this off and they think it's going to get better, or just from life circumstance they don't want to go ahead and get this done or schedule time in. So you don't have to wait forever.
Yeah, that would be my recommendation, because get the other one done in November, and then I'll be good to go back to golf.
Yeah, bionic man.
Well, that pitching was a little rough, especially that landing leg.
Craig, thank you for your call.
I just wanted to say I appreciate your efforts and your work, because I'm benefiting from it.
Thanks, Craig. Good luck to you.
All right, thanks.
Thanks so much for your call this morning, Craig. You never know exactly who's going to join us here on The Fan. We'll go next to Amy in Springfield, Massachusetts. Thanks for holding on so long, Amy. Good morning. Welcome to The Fan.
Good morning. I just wanted to advocate for children of parents who need joint replacements to not only encourage them to do it when they need it, but also, as the previous caller said, encourage them, A, not to wait too long, and B, just as we would prepare for a marathon by training, just as you don't put things in the garden without composting the soil, to talk to their docs. And I want to ask the doc's opinion about getting PT beforehand, because my father has had 2 hips replaced, which he did phenomenally well with at the hospital for special surgery. My mother has had a knee replaced and most of her spine fused. And the thing that made the biggest difference was seemingly support before and after. They were in their 70s and 80s when they had their surgeries, and lots of stretching and PT seemed to help them recover much faster than they were expected to. And I want to ask the doc where he holds on that.
Okay, I'm going to let him respond to you on the air. Thank you for your call this morning, Amy.
Thanks, Amy. I agree with your sentiments wholeheartedly. I think we call it pre-therapy is very helpful, and certainly post-operative therapy is extremely important in affecting a good outcome in any type of surgery, especially when it comes to joint replacement surgery. My part of the overall treatment for a patient in the operating room takes somewhere around an hour to do for a primary knee or a primary hip replacement. The patient, as well as the family and the therapist or the occupational therapist and physical therapist, have a much bigger part in the recovery process, and the family support system should not be underestimated as well, because patients can go home from the hospital directly after hip or knee replacement if they have good family support and are educated about that. And that, in many ways, is good for patients to get out of the hospital environment or out of the rehab environment and going to their home, because that in and of itself, in my opinion, is therapeutic.
We're talking with Dr. Michael Ciminiello on our program on The Fan this Sunday morning. Unfortunately, we're not going to be able to get to any more folks via the phone. The clock is our enemy here. Boy, this show is whipped along. This morning, we mentioned earlier your website is Hip and Knee Doctor, and that's spelled out HIPANDKNEEDR. That's all as if it's one word, .com. You've shared an awful lot with us in the course of this discussion, and I guess we can say literally the password for today is meniscus. As I told you, it would definitely come up in discussion here. You see the intensity, the depth with which people bring to
absolutely.
To this
Absolutely.
Rick Wolf is along after our top of the hour update at 8 o'clock with the Sports Edge program here on The Fan. Thank you very much for joining us and sharing this information. We'll definitely have to have you come back and join us again.
I would love that, Bob. It was a great experience for me, and I look forward